Picture this. You've got a patient sitting comfortably in front of you. By every standard measure, you're looking at a perfectly healthy abdominal exam, right? I mean, there's absolutely no jaundice, no ascites, no spider navy. But then, you noticed one very specific physical clue, and in an instant, the entire clinical picture flips upside down. Welcome to today's Explainer, where we're going to build out the truly fascinating realities of liver transplants, entirely from first principles. So, you're doing this physical exam. It looks deceptively normal until your eyes catch that scar on the abdomen. That single visual cue, it completely rewrites everything you thought you were dealing with. Suddenly, you're no longer asking, hey, what disease does this liver have? Scratch that. Your whole mindset has to shift to evaluating a transplanted graft. You're now asking yourself, just how well is this new liver functioning, and what might be quietly threatening it? And the specific scar we're talking about? It's the famous Mercedes-Benz incision. It really is unmistakable. You have 3 curved incisions meeting right in the central upper abdomen, and it looks, well, exactly like the car manufacturer's logo. It is the absolute signature physical finding of a liver transplant. Now, in the early post-op days, you might also spot a T-tube in there for biliary drainage. But here's a really fascinating quirk. The transplanted liver itself, it's not going to tell you why the patient originally needed it. To figure that out, you've got to look at the rest of the patient. Things like tattoos or track marks might hint at a history of viral hepatitis, while the patient's general body habitus could point you toward a metabolic or alcohol-related original diagnosis. Okay, let's map out how we're going to tackle this today. We'll be hitting 6 main areas. First, shifting indications. Second, contraindications. Third, prognosis and recurrence. Fourth, the transplant jaundice differential. Fifth, the complication timeline. And finally, number 6, immunological tolerance. Let's get right into it. Section 1, shifting indications, the massive epidemiological pivot. We actually need to bust some traditional medical teaching right out of the gate here because the reasons people even get liver transplants have fundamentally changed. Traditional teaching always hammered home that hepatitis C and alcohol-related disease were the dominant reasons. But if we compare the U.S. data from 2013 to 2022, the landscape is totally different. The invention of direct-acting antiviral therapy was an absolute game changer. I mean, it practically eliminated hepatitis C as a leading indication. It dropped from roughly 28% of U.S. listings to under 5%. We can just cure it now before it breaks the liver. So nature abhors a vacuum, right? In its place, alcohol-associated liver disease and MASH, that's metabolic dysfunction-associated steatohepatitis, have completely surged to fill the gap. In fact, MASH is currently the leading cause for candidates who also happen to have hepatocellular carcinoma. Section 2. Evolving contraindications, absolute versus relative. So it is absolutely crucial to know what actually prevents a transplant from happening in the first place. But keep in mind, these rules are a moving target. We generally split contraindications into 2 buckets, absolute and relative. Absolute means the transplant just genuinely cannot succeed or ethically proceed. We're talking active extrahepatic malignancy, severe comorbidities, uncontrolled infection, things like that. But relative contraindications, those are way more nuanced. Advanced age or specific psychosocial concerns live in this bucket. And here's an incredible example of how medical progress literally rewrites the rulebook. HIV. Historically, being HIV positive was an absolute barrier. No way. But today, because we have such highly effective antiretroviral therapy, well-controlled HIV has moved firmly into the relative category. Carefully selected HIV-positive patients get transplants now, and they have excellent outcomes. Section 3. Prognosis and disease recurrence. Now, you might be wondering what actually determines if this new graft is going to survive long-term. The good news is, overall prognosis is fantastic. 10-year survival easily exceeds 70%, but that number hides a lot of variation based on the original disease. For example, primary biliary cholangitis, PBC, and autoimmune hepatitis have incredibly favorable outcomes. Why? Simple. They rarely recur in the new liver, and if they do, it's usually pretty mild. On the flip side, you have the poor outcomes, historically driven by malignancies and untreated hep C. The driving force here is just recurrence. Malignancies spread through occult micrometastases that were already hiding there during surgery, and untreated hep C would literally just reinfect the brand new liver. So the golden rule is this. A patient's prognosis tracks almost perfectly with how likely their original disease is to just wake up and restart in the new tissue. Section 4. The transplant jaundice differential. Let's pull this back to the bedside for a minute. If your transplant patient has no jaundice, that is a stellar sign of good graft function. But if they start turning yellow, you have to literally throw your standard diagnostic playbook out the window. A transplant patient with jaundice has a totally unique differential. You've got to immediately start thinking about a biliary stricture, outright graft rejection, maybe a hepatic artery or portal vein thrombosis, disease recurrence, or even drug-induced liver injury from their own massive immunosuppressive regimen. Every single one of these possibilities demands a completely different intervention. You just cannot run the standard generic jaundice algorithm here. It won't work.
Section 5. Timeline of transplant complications.
Now, the specific dangers these patients face, they don't just happen randomly. They cluster in a remarkably predictable timeline. Early on, we're talking the days and weeks right after the operation, infection is the massive dominant threat. The surgical and biliary connections are healing, and the immunosuppressive burden is absolutely at its peak. But as you zoom out, months and even years down the road, the whole risk profile shifts. Those late-stage risks become cardiovascular disease, renal failure, and malignancies. Skin cancer, believe it or not, is actually the most common. And really, this late phase is just the cumulative, heavy metabolic toll of taking powerful immunosuppressive drugs day in and day out for years. To really put that into perspective, let's look at one super common, concrete example of this trade-off, tacrolimus. It is a cornerstone drug for preventing rejection. Absolute lifesaver. But it is incredibly notorious for causing new or worsening hypertension. This perfectly explains a scenario that throws a lot of people off. You have a transplant patient sitting there with wildly uncontrolled blood pressure, yet their liver graft is functioning flawlessly. It's wild, right? The very drug keeping the new liver alive is simultaneously beating up the cardiovascular system.
Section 6. A unique immunological feature.
Okay, I have to share this because it is just a brilliantly weird fact about liver biology. Compared to other solid organs, the liver is kind of a show-off. It has this unique capacity for something called spontaneous immunological tolerance. What does that mean? It means a meaningful subset of liver recipients can actually maintain perfect graft function, even if you significantly drop or, in some very rare, carefully chosen cases, entirely stop their immunosuppression. Without triggering rejection, you literally cannot do this with a new heart or a new kidney to anywhere near the same degree. The liver just has this incredibly distinct immunological handshake with the rest of the body. Obviously, this is only attempted under hypervigilant specialist supervision, but biologically, it's amazing. So, tying it all together, how do we manage these patients over a lifetime? Well, it relies on strict systemic logic. Ongoing care means relentlessly monitoring both liver and renal function. We have to be super aggressive about preventing osteoporosis. That's a huge risk because of both the prior liver disease and the heavy steroid regimens they were on. Beyond that, it's all about staying up to date on vaccinations, maintaining strict hygiene and diet, and just constant vigilant surveillance for those specific timeline complications we just talked about. Which brings us to our final thought today. The next time you see that distinctive Mercedes-Benz scar, I want you to consider the ultimate trade-off. Yes, we have successfully replaced a failing organ. It is a modern medical miracle, no doubt about it. But are the heavy, lifelong medications required to keep that new liver alive quietly creating an entirely new set of diseases of their own? It's a complex, incredibly fascinating reality of post-transplant life, and it fundamentally changes how we have to approach patient care. Thanks so much for joining me on this explainer, and remember to always keep questioning what you see at the bedside.